there, but because of the present COVID situation, I was not able to travel. But however, I thought I could share my experience on the Zoom. So as Professor Ayap Cherian always says, the virtual learning is always there, but it's nothing like the hands-on experience. Once you do the hands-on on the cadaver, then it's completely different. So without much ado, I will start sharing my screen. And I just want to tell a few words. I went to Nepal, actually to Bharatnagar, to demonstrate skull-based surgery. And I'm really thankful to Professor Ayap for having me here again. So I just want to, I can see a lot of young neurosurgeons here and who are going to be aspiring and very good skull-based surgeons. I just want to tell you one small thing. Before I started doing my skull-based work, I did around 80 cadavers. So before I even did my first case, I did 80 cadaver dissections. And the most important thing you'll have to try to do on a cadaver is try to practice what you're going to do in a live patient. This is something which I want to tell all the young neurosurgeons out there, because some of them actually pluck and pull, and they do not do it as you do it on the inside the OR. But honestly, if you try to replicate whatever you are doing in this cadaver, the same thing you're going to do in the live, then I think you will be far ahead. The first thing I want to tell about endoscopic skull-based surgery is that it is already an evolved field. It's not an evolving field. There are several centers in the world doing a lot of good endoscopic skull-based. And I'm sure that in India also, there are so many centers doing that. I'm going to start. Can I share my screen, Professor John?
Yes, go ahead.
Okay. This is it. You are. You are.
There you go. You're on the way.
Okay. Okay. So I just want to tell a few salient features before you get started on doing your cadavers. So I am basically doing skull-based. We do a lot of skull-based work, primarily both on the sagittal and the coronal planes, maybe around 10 cases a month or so. Basically, I want to tell you that most of our neurosurgeons are microscopic neurosurgeons, and to convert themselves into an endoscope is a little difficult because you're already well versed with the microscope. The only problem with the microscope when you do endoscopic skull-based surgery is that it gives tubular vision. It gives very tubular vision, and so you're not going to get a panoramic view. But when you use an endoscope, you're going to have a principle of divergence. So that's a principle of convergence from the microscope gone on to the principle of divergence, and you can just take your eye right into the skull base, and so you can see the structures better. But only problem is some people complain that you have a 2D effect rather than getting the depth perception. But I'm sure that with practice, you will start developing that. The most important part of this learning would be try to release the cuffing effect. So what's the cuffing effect? When you're operating with a narrow corridor, then it becomes very difficult for you to operate inside when there is a complication like, a bleed from the carotid or the cavernous sinus. So try to increase your exposure. So I always say when you practice skull-based surgery, you have to, endoscopic skull-based surgery, you have to open up and spend a lot of time for exposure. Never have bottlenecks during surgery, and that's going to be the primary goal of your surgery. But what is the real bottleneck for a neurosurgeon? To handle the endoscope and to have a hand-eye coordination. What's the bottleneck for an ENT surgeon doing it? It's actually the knowledge of anatomy, intracranial anatomy. So basically, we should understand that endoscopic skull-based surgery is a teamwork. It's not one person. So please, my dear friends, when you're doing skull-based surgery, cadaver dissection, please, two of you combine and do it. Never do it like hold the scope and use the instrument. If you do that, you can never progress on in doing a lot of complicated cases. So, of course, I'm just going on to how to start doing endoscopic skull-based surgery. I formed a checklist. So basically, this is how you get started. When you start operating, you have three positions of the head. So try to have what's called, this is called the neutral position. So that's a neutral position. Try to have a neutral, of course, in the cadaver you can't do that, but while doing surgery, if you want to do the odontoid, so this is what is called the dynamic head positions. So if you put it on a frame, you can't do that. So if you want to do the odontoid, if you want to do an odontoidectomy, then you can put the neck in the flex position. If you want to do anterior craniofacial resection on the frontal lobe, then you have to extend the head. So you can actually keep changing the head position, and that is little difficult when you put it on a frame. That's why we don't fix the head when we do skull-base surgery. And second is important thing is that many people hold the scope in a different way. This is how I generally hold the scope when I do endoscopic skull-base surgery. See, it's held like a flute. It's held like a flute, and this is the position you have to adopt when you do four-handed surgery. Just have a look at it. You try to do the same thing in the cadaver. Please do not, a single person, do not do it. If you do that, there's no use in doing this cadaver at all. So one person should hold the scope and the other person should enter through both the nostrils. So it's the binostril technique, and have the camera cable. So I generally use the Spice camera. Now, of course, the 4K and the Rubina have come out. So use the best camera possible and then put the cable on the left of your patient. And whenever you introduce the endoscope, introduce it using the flexibility of the ala. So you have to pull the ala up, and that's how you introduce the endoscope. And the instrument should always be on the floor. That's very important. So never try to, these two should not cross over. If it crosses over, then you will have what is called the crossover effect. And see, that's a crossover effect. When you do that, you will have a problem during surgery. And the instrument should be never above the endoscope. The instrument should not be over the endoscope. If you're having the instrument above the endoscope, then you're doing something wrong in endoscopic skull-base surgery. And when you use angle, of course, in skull-base surgery, I try to avoid angle telescopes. But when you want to look at the suprasellar cistern or, cavernous sinus or things like that, I might be using a 30-degree, but they are all only for visualization, not for operating. Why? Because we don't have instruments. If it starts bleeding there, we don't have instruments to go laterally or superiorly to, control the bleeding there. So these are basic things I want to tell you. And of course, you should never, suppose you move the left hand and the right hand, the left and the right should move simultaneously. This is very important. The scope and the instrument, you should have only a distance of around 2.5 centimeters. So how do you measure it? You have in Carl stores, you have a suction which is calibrated. Have that in your hand, and then you can actually visualize. So this is a craniopharyngioma. I'm just operating. Use the same instrument. Don't try to change instruments. I have a set of instruments which I use for a particular step. And always try to have an aerial view. This is called the aerial view of the surgery. Try to have an aerial view. And when you're operating near the perforators, this is very important. I've seen many people pulling at a craniopharyngioma. This is actually dangerous. Skull-base surgery is all about microdissection. Whatever you do from outside, it's exactly the same. So don't ever try to pull any structure inside. For example, a tumor like a pituitary. I never use curettes. Curettes to me are not the great instruments to do pituitary surgery, even if you do an extracapsular dissection. So here we are. Then if you go for the suprasellar, never use the instrument above the endoscope. This is again and again, I tell you, just keep seeing that. And in the nasal cavity, many people have a problem with bleeding. Many people say, I have bleeding, so much of bleeding when I do the nose. So try to use adrenaline soaked gauze piece. So I use 1 in 1,000. 1 in 1,000 adrenaline soaked gauze piece just to control the bleeding. That's very important. And then try to remove all that bone. See, this is a cavernous, transcavernous approach. And I remove all that bone in the pterygoid wedge, in the transpterygoid approach. See, when the tumor is going lateral to the carotid, you have to remove all this bone to expose the cavernous sinus. So your boundary should be the V2 and the median. And here you can see the internal carotid artery right there. So you can actually transpose this carotid all around to get the tumor out. So again, the most important thing I want to tell you, my dear friends, never have a camera tilt. If you have a camera tilt, it gives a false sense of perception. So this is all the basics I want to talk to you. And of course, I can show you any number of cases like the cranio, which we are operating. And then you never try to pull that. And then you can, there are two kinds of dissections, which I always say. One is a blunt and the second is a sharp dissection. Previously, we were actually doing the blunt, but now we have changed to sharp dissections, especially near the cranial nerves and the perforators. And then you can do all these, you can see how the optic chiasm is seen, and you can go just above to see the anterior circulation. And of course, a pituitary like this, if you want to remove, then you have to give a good exposure. So proximal bone exposure, try to expose the bone very nicely, and then you can actually manipulate the carotid. You see the carotid is being hooked here and moved and transposed. And of course, you can get beautiful views of the cavernous triangles. Of course, the Kawase, yesterday, I think Professor Cherian showed you all the dissections of the triangles. We can do it endoscopic as well. And you can see here the third ventricle, and you can see such tumors, huge tumors being removed. But I honestly believe that all this boils down to cadaver dissections. So unless you do a lot of cadaver dissections, which Dr. Ayap, this is a dissection I did in Pakistan. I just want to show you that only if you do a lot of cadaver dissections, I think you will get a finish. You have a book by Carl Storrs. You can ask that book from Sunil. I just want to brief you on to how to get started. I'm sure that all of you are very enthusiastic. I'm sorry I couldn't make it there because of the corona. I'm sure that you're all going to, I don't want to waste your time, stand between you and the cadavers. You can get started, and all the very best. And thank you for this opportunity, my dear Professor Cherian. And I really congratulate you for this institute which you have created. We are all so lucky to have you. And I'm sure that I'll be associated with you in the days to come and months to come. Thank you very much. And I also thank Professor John Bennett from Miami. He's always like my friend, always there. I don't know when he sleeps. That's the only problem. And so nice of you to transmit, to the whole world. So that was just a brief introduction onto endoscopic skull base. Over to you, Professor Cherian. In case you have any doubts, my dear participants, you can ask me. So Mr. Sunil Verma of Carl Storrs has all my videos of cadaver dissections and, so many surgeries. If you want, he can play it for you as well. And you can ask for the videos from him. Any participants have any questions to me? It'll be a pleasure for me to answer the questions.
Okay, the floor is open. Anyone that has a question from the panel or wants to comment or just say hello to Dharan?